So you have a stepwise cognitive decline with vascular dementia because you have an identifiable stroke that usually affects either the frontal lobe or the occipital lobe, some part that's really needed in one cognitive domain. And then you usually recover a little bit, but there's always some issues. And then after that, if you have another stroke or more buildup of scars in the brain because you continue to have diabetes or because of genetics, then you continue to have these silent little hits in the brain that cause you to keep going downwards. The real prognosis is how well you do, depends on if you can prevent further strokes and minimize the amounts of scars that build up in your brain. Usually patients present with more of a slow cognitive decline, so it seems like they have trouble with naming or language fluency, and it seems subtle. And when you take a picture of their brain, you see tons of those white spots that I showed you a couple of slides before that tell you that you have had a lot of damage or old strokes that have built up over the years that are causing dementia. Again, executive functioning is mainly impaired, and more so than memory. So this is one of the dementias where you have more language and executive functioning problems, and your episodic memory seems to be spared. And if you remember, in Alzheimer's disease, the hippocampus, which is part of the temporal lobe, was found pretty deep inside the brain. And structures that are involved in stroke tend to be more on the outer part because that's where more of the blood vessels supplying the brain are. And that's why memory seems to take less of a hit than other structures such as language. Vascular dementia, however, do have a lot of neuropsychiatric symptoms, just like Alzheimer's disease, including depression and psychosis. And in addition, they have these three unique types of neuropsychiatric conditions, which we'll talk about, and they're all named for Latin terms. The first one is called abulia, and that means that you have an absence of willpower. This happens if you have a lot of strokes affecting the frontal lobe of the brain. And what happens over time is that you become less willing to engage. And you just kind of sit around like a lump and you don't have any willpower to get up, to do activities, to interact with people. And in its most extreme form, patients just kind of look like a sack of potatoes staring at the wall. And it's not really bothering them, but they just seem like they have no willpower to live. It's very sad when it happens, and it's really not to any fault of their own, but it's because a part of their brain has been damaged by a stroke. The second really fascinating and sad condition is called apathy, and that means that they have a lack of concern or enthusiasm. And that's really also a frontal and temporal lobe problem. And so basically, patients just aren't really interested in doing things and don't have as much enthusiasm as they did in the past. Abulia is a more extreme form of apathy, and apathy is more of a milder form. The most striking condition that can happen to patients is called pseudobulbar affect. If any of you have seen the movie Joker with Joaquin Phoenix that came out earlier that fall, they tried to show him as having pseudobulbar affect, which is a neurologic condition where patients uncontrollably laugh or cry, but it's out of context. So they usually laugh during a sad movie or just randomly, or they start crying even though it's a really happy event or there's just nothing going on to make someone cry. And when you ask them, they say they don't feel sad. They don't feel particularly like they need to laugh, but it just comes out and they cannot control it. So it has nothing to do with how they're actually feeling inside, but it's because of dysregulation of emotional centers. It causes people to laugh or cry uncontrollably, even though they're not feeling those emotions. So they portrayed Joker as having this condition in the movie. They kind of made it a little extreme, but in general, patients do laugh or cry uncontrollably, just like they showed in the movie, usually due to tumors or strokes in the brain. A lot of patients, because of buildup of strokes with vascular dementia, can have pseudobulbar affect, and there's a medication called Nudexa that can help with it. Now we're going to move on to the third most common form of dementia called frontotemporal dementia, or FTD. What's interesting about this disease is that it's also a neurodegenerative disorder like Alzheimer's, and it's heterogeneous. And what I mean by that is that there's lots of different causes and lots of different flavors within frontotemporal dementia. What happens in frontotemporal dementia is there's a buildup And what happens is it's called Pick's disease. You have significant personality changes early on. This is really striking and different than all the other Alzheimer's, where you usually have memory or executive functioning or cognitive decline in some way. But in frontotemporal dementia, also called Pick's disease, your personality is the thing that changes quickly. In addition, language is really affected early on, and you develop something called aphasia. Aphasia means that it's your loss of ability to either produce language and or understand language. So an example is you can have an aphasia where you are speaking fluently, but you have no idea what the words mean, and when people talk to you, you have no idea what it means. You can also have an aphasia where you understand everything, but you just cannot get the words out. So you kind of sound like a typewriter where you say one word and then stop. So in frontotemporal dementia, patients have really personality changes and they can't speak or communicate well. In addition, patients can also have secondary neurologic diseases in addition to the FTD, which is debilitating, including ALS or Lou Gehrig's disease, where you have progressive weakness, or Parkinson's disease. Frontotemporal dementia often begins in your 60s, and it's one of the more common causes of early onset dementia. So if someone less than 65 is coming to me with signs of dementia and they score low on their MoCA and their family is concerned and they're not able to do their activities of daily living, if they don't really fit the Alzheimer's picture with visual spatial stuff early on, and it's more their language and they kind of are acting oddly and have more psychiatric symptoms, I tend to think more of FTD or frontotemporal dementia more than Alzheimer's, particularly in the younger people. So within FTD, as I said, there's different subtypes. One of the more common FTDs is called behavioral FTD. And this is in more than 50% of patients with FTD, they have the behavioral subtype. And basically what happens is kind of overnight, they have a drastic change in personality. Mainly they are disinhibited, so they're touching or kissing strangers, they pee in public, they just do totally inappropriate things that they would have never dreamed of doing in real life before the illness. And it's really sad because, some people who are just like normal, upstanding citizens start doing this, and it can be embarrassing for their family members, but they really can't control it because it's a dementia. There's a loss of empathy, so they tend to start to seem cold or lacking emotion. They have hyperorality, which means they like to put lots of things in their mouth and they like to eat a lot more, so they gain a lot of weight. They have compulsive behavior, so they need to like clean their house over and over again or have kind of OCD tendencies. And the main striking thing is they have no idea that this is going on really. Like they're doing all these things and they're changing, but they don't realize that they're different and they really deny the changes that their family members are noticing. So it makes it really, really hard to diagnose and treat a patient because they really refuse to see that they have these problems. So when you want to ask, a patient if they have been having these behavioral changes because it is one of the main subtypes of FTD, you can ask their loved ones some questions. Has the patient done or said anything in public that's embarrassed other people? Do they seem to have a lack of disgust, so they kind of do more, disgusting things? Do they seem indifferent during, happy occasions or seem less warm or affectionate? Have their food preferences changed? Are they eating a lot more or eating different things? Have their table manners declined? Do they seem more concerned with like tending to the watch or the clock than engaging with humans? That seems to be more of compulsive behaviors. Is there a change in their sense of humor? Have they developed new hobbies, especially with a religious or spiritual bent? For some reason in FTD, people tend to become a lot more religious, which is one of the signs, and it's kind of interesting. So frontotemporal dementia, what's different about this is that it's very highly heritable. So if someone in your family has it, you have more risk of developing it. 10 to 25% of cases are autosomal dominant, which is really remarkable because in Alzheimer's, it's less than 1% that are autosomal dominant. So this is much more of an inherited disease. And there's been 3 different mutations that have been identified, including a mutation in tau, which is interesting because we know that tau is involved in Alzheimer's, so there's an overlap. A gene called C9orf72, which is also involved in ALS, and then another gene called granulin precursor gene. And on autopsy, when we look at their brains, they seem to have swollen neurons and a loss of myelin, so there's just some kind of degeneration of the neurons that we don't have a better idea about. When you look at their MRIs, The MRIs tend to be a little bit more helpful in FTD than Alzheimer's because in Alzheimer's it takes a really long time for the beta amyloid and tau to actually cause shrinkage that we can pick up on imaging. Whereas in FTD, we tend to pick up a frontal lobe and temporal lobe degeneration more. And that's why it's called FTD, because the frontal and temporal lobe parts of the brain start to shrink and degenerate. And that's why we have loss of impulse and personality changes and language problems, because these cognitive domains are represented in the frontal and temporal lobes. If you see here on MRI, these are the temporal lobes. And in this patient, they're pretty shrunken compared to this patient where there's a lot more space here. So that just shows that the temporal lobes are being eaten up. And same here, this is a nice healthy patient with frontal lobes that kind of go all the way to the edge. And over here, it's kind of harder to tell, but there is some shrinkage of the frontal lobes. This is a PET scan where basically you inject a radioactive dye and with glucose, and cells need glucose to function. And so active cells pick up the glucose and then it lights up in these pretty pictures. In normal brain, this is what it should look like. So you just see the the yellow, the orange, the green. These are all healthy cells, and the blue is like inactive or empty space. In Alzheimer's disease, you see kind of more this greenish blue or empty space and degeneration of brain, more kind of in the parietal lobe. But in FTD, it's more up here in the frontal lobes that are affected. So to review, FTD is more of a common form of dementia in younger patients, so less than 65. And most likely you have two things: behavioral changes that are pretty extreme and your language is really affected. It's called aphasia. Less so is memory involvement. So this is just a prime example of how dementia can cause cognitive domain dysfunctions that has nothing to do with memory, but yet it is a form of dementia. And on MRI, we tend to see frontal and temporal lobe shrinkage. And unfortunately, just like most dementias, there is no treatment because we have no way of stopping shrinkage of the brain and the toxic developments that occur to cause death of neurons. But there is more and more research being done to help figure out how we can treat these patients going forward. Lastly, we're going to talk about a really interesting form of dementia called DLB, or dementia with Lewy bodies. This often happens in patients who seem to look like they have Parkinson's disease, and on top of that have a lot of cognitive issues and dementia. And so basically these patients, again, really don't have a lot of memory impairment, but more so their cognitive domain that is affected is attention and executive functioning. So they have a really hard time paying attention and completing a task, and they're very impulsive. Early symptoms include difficulty driving. And why that is because you really actually need to have a lot of attention and impulse control. You need to look at stop signs. You need to be able to read directions. You need to be able to let people go before you and drive safely. And you have to be able to know how much to turn the car without hitting something, and you have to be able to judge distances. And so patients with this, because of their lack of attention, really have a hard time with driving. The core clinical features that really cinches a diagnosis of dementia with Lewy bodies is that they have visual hallucinations. And I know that I've mentioned that all the other dementias can also have psychiatric problems and hallucinations, but what's key about dementia with Lewy bodies is they have these really peculiar visual hallucinations in particular, where they see either really mini people called Alice in Wonderland syndrome, because they basically imagine like little munchkins all over the place, or they tend to see little furry animals scurrying around their room like squirrels and stuff like that. It can be pretty frightening, and because it seems very, very vivid and real to the patient, but you can be in the same room and not see anything, but they're really responding and interacting with these hallucinations. So again, they see either really mini people or squirrels and little furry animals. In addition, they have a lot of trouble with sleep. In particular, they have something called REM behavioral sleep disorder, where basically they act out their nightmares. And so they kick and punch and get out of bed and fall out of bed during dreams because they can't help but act it out. And this is really a sleep disorder because in most patients and people, all of us, when we sleep and dream in REM sleep, there is a process that happens that paralyzes our muscles so we don't act out our dreams. But in patients with dementia with Lewy bodies, for some reason, this muscle paralysis doesn't happen and they act out their dreams very vividly.